Dr. Myers is the Director of Community Education and Partnerships for the Family Planning Division at the University of Utah's Department of Obstetrics and Gynecology. Dr. Myers will be talking today about unintended pregnancy and birth and the context and implications that accompany. Thanks, Kyl.
Hi, everyone. I'm really happy to be here with you this afternoon. I'm going to give a brief overview of unintended pregnancy with some national and local data. My goal, though, is to really pique your interest so that you want to learn more about unintended pregnancy, and especially in the community that you're living in and working in. So my hope is that you'll be inspired to use your position as in the patient care team to improve the rate of intended pregnancy in the population you serve. I do want to acknowledge that we've been so fortunate to have this this whole series sponsored by a March of Dimes community grant. Okay. So I'm Kyl. I am a sociologist by training. I direct a statewide contraceptive initiative in Utah. It's called Family Planning Elevated. And FPE is housed in the Department of Obstetrics and Gynecology here at the University of Utah School of Medicine. I'm professionally and personally very invested in helping Utahns have control over their fertility. I'm a native Utahn. I've lived all over the state, and I think it's so important that people have the ability to decide if and when and how many times they get pregnant. I believe contraceptive education and access is one of the greatest tools that we have to reduce inequities in our communities. So it's great to see how many people we have participating in this webinar that are all across Utah. So with your help, we're creating a network to expand contraceptive access services across the state and improve people's lives. I don't have anything to disclose. After this presentation, you will understand how unintended pregnancy is defined. You will be able to identify population-relevant characteristics that are associated with increased risk of unintended pregnancy. And you'll learn about social and health outcomes that are associated with unintended birth. Two takeaways that I hope stick in your mind are, the first is 1 in 5 new moms in Utah report their pregnancy was unintended. And this number jumps to 1 in 3 among new moms who were uninsured at the time they got pregnant. And the second takeaway is that access to contraceptive information and the full range of contraceptive methods without cost barriers dramatically reduces the rate of unintended pregnancy. And before I move on, I just want to acknowledge that not all people who experience pregnancy and birth or who are at risk of birth identify as women. So we take care of non-binary folks and transgender men in Utah who are at risk of pregnancy. And it's important to be inclusive of all of our clients and members of our community. But during this presentation, I'm going to use the term woman, but I want to acknowledge our diverse population. Dr. Tarak introduced this slide last week, and I wanted to show it again because I think it's a good illustration of of many women's reproductive life goals. To put the importance of contraception into context, on average, most people want about 2 children. And so this means that most women spend 3 years of their life either pregnant or trying to get pregnant, and 30 years trying to avoid pregnancy. So many women spend most of their reproductive lives using some method of contraception, some type of behavior to prevent an unintended pregnancy. And women's ability to avoid unintended pregnancy is affected by a lot of social factors like their income or their insurance status or their geographic location or the culture they're in, and we'll touch on that. First, let's go over what defines a pregnancy as unintended versus intended. So an unintended pregnancy is defined as a pregnancy that was either mistimed or unwanted. So this means at the time someone got pregnant, they either never wanted to get pregnant or they wanted to get pregnant in the future, but not at that time. So about How long has that been? Okay. So someone may experience an unintended pregnancy, but be happy about it. And somebody may experience an unintended pregnancy and be upset about it. So we need to remember that people are very resilient, and unintended pregnancies can certainly be wanted pregnancies. That said, there are disparities. So with some people, they are more likely to experience an unintended pregnancy than others, and some people's lives may be more negatively impacted by an unintended pregnancy than others. So instead of getting too into the weeds about whether or not unintended pregnancy is inherently bad, we really want to turn our focus to increasing contraceptive equity, to close the gaps in unintended pregnancy rates between these different groups. We also have to acknowledge that not all pregnancies are ending with a live birth. So some pregnancies end in miscarriage, some pregnancies end in abortion, especially unintended pregnancies. So we need to be mindful that when we're talking about unintended pregnancy rates, that we can't just interchangeably use the term unintended birth rates because they are different. This image illustrates U.S. pregnancies by intention status, so just what we went over with those definitions, with 55% being intended and 45% being unintended. And in that unintended, we see about 27% being mistimed, so people who didn't want to get pregnant right then but wanted to get pregnant in the future, and about 18% being unwanted. They did not want any children or any more children, or any pregnancies. So this graph is from the Guttmacher Institute, which is an excellent resource for information about sexual and reproductive health research that I'd really encourage you to check out. It's just guttmacher.org, and they have a lot of state-level information for Utah. Now, this map illustrates how unintended pregnancy rates vary widely in the U.S. So the different colors represent the number of unintended pregnancies per 1,000 women aged 15 to 44. So the lighter colors represent lower rates of unintended pregnancy, and the darker colors represent higher rates of unintended pregnancy in those states. So you can see that Utah has a lower rate of unintended pregnancy compared to the rest of the country. In 2010, among 1,000 Utah women aged 15 to 44, about 32 to 40 of them experienced an unintended pregnancy. And several factors contribute to Utah's lower unintended pregnancy rate than the national average. So we have fewer teenage pregnancies in Utah. There are some cultural norms surrounding younger age at first marriage and pro-family values. There's relatively high contraceptive use in Utah compared to other states. Generally in Utah, contraception is very acceptable. But I want to zoom in on Utah and highlight some geographic disparities. In Utah, we have 13 local health districts. So we have 29 counties, but they all fall into a local health district. And between 2013 and 2015, 1 in 5 births in Utah was reported as unintended. And these data come from a survey called PRAMS, which you can learn more about on the Utah Department of Health's website, and there's a link there, and we'll make sure to include it on the website as well. But in the PRAMS survey, there's a question that asks, so what I want you to keep in mind here is people are getting this PRAMS survey within about 6 months of the time that they've had a baby. So they are parents. And they get asked, thinking back to just before you got pregnant with this most recent child, how did you feel about becoming pregnant? And then they are asked to check one answer. They can answer, I wanted to be pregnant sooner, I wanted to be pregnant later, I wanted to be pregnant then, I didn't want to be pregnant then, or at any time in the future, or I wasn't sure what I wanted. And so women who wanted to be pregnant later or didn't want to be pregnant were categorized as having an unintended pregnancy. And so 1 in 5 of these new Utah moms who got this survey reported they didn't want to be pregnant or they wanted to be pregnant later. And this number jumped to 1 in 3 among new Utah moms who didn't have insurance at the time that they got pregnant. Because we have REPP participants on this webinar from all over the state, I'll briefly go through this list so you know the unintended birth rate in the local health district that you live and work. So at the state of Utah, we see 22% generally of births are reported as unintended. In Bear River, that's 24%. In the central local health district, that's 22%. In Davis, it's 21% of births are reported as unintended. Salt Lake, 23%. In San Juan, Southeast, and Southwest, we have to use some caution when we're interpreting these estimates because they have a relative standard error greater than 30%. They just don't meet the standards of reliability. But still, in San Juan, we see 44%, Southeast 14%, and Southwest 24% of births are reported as unintended. And in Summit, 25%. In Tooele, we see 31% of births are unintended. The Tri-County is 26%. Utah County is 17%. Wasatch, the numbers are too small. We can't report a number. And in Weber, Morgan, there is 32% of births reported as being unintended. So I'm just hoping that, I know we have people from all over the state, so being able to see that there are some very drastic differences from sometimes county to county or local health district. So in Utah, like in the U.S., certain groups are more likely to experience an unintended birth than others. And so these are individuals who are younger than 20, those with less than a high school education, people of color, those with Hispanic ethnicity, people who are unmarried, those with an annual income less than $15,000, people who don't have insurance or who have Medicaid prior to pregnancy, people who smoked or drank in 3 months before pregnancy, and those who had a baby in the 20 months prior. We just see some statistical significance with unintended pregnancy in these populations. But something that I want everybody to be really mindful of is we're not, we don't want to be singling out anybody specifically on this list. What our job is as healthcare providers and researchers and patient advocates is to really take this 30,000-foot view and see how are we missing them? What's going on? For people, people who are younger than 20 or those with less than a high school education, maybe they're missing out on some contraceptive education. For people who have incomes less than $15,000 or don't have health insurance, how are they even affording to get into a health clinic to begin with? So we really need to be addressing the systemic issues rather than trying to single out any subgroup of a population. We really need to be making sure that we're contributing to equity in healthcare access. So this is a national graph, but I think it's very telling. So this graph is also from Guttmacher, and it shows the rates of unintended pregnancy by income bracket from 1981 to 2011. So on the left, we're at 1981, and you can see the trend of unintended pregnancy rates among women based on their income level. So for women with incomes above 200% of the federal poverty level, so they're the darkest line on the bottom, their unintended pregnancy rate has been cut in half since 1981. While the unintended pregnancy rate for women with incomes below 100% federal poverty level has actually increased. And so we have seen generally in the United States the unintended pregnancy rate is decreasing. For certain populations, it's increasing. And so we really need to be able to zoom in and see these economic disparities to really address these issues. So the drops that happened in 2008 are largely influenced by the Affordable Care Act and the contraceptive mandate, which helped women access contraceptive methods, including IUDs and implants without cost sharing. But even with the ACA, you can see that we have a very long way to go to close that unintended pregnancy gap between low-income women and women with more resources. In a few weeks, I'm going to be talking about some resources and programs that are available in Utah that can help you really serve the contraceptive needs of the patients that you serve who are most in need. And we have programs that can help them access effective methods of contraception without cost barriers. Like the headline on this graph says, modern contraception works. So on the left, the pie chart represents the 43 million women in the U.S. that were considered at risk of pregnancy in 2008. And you can see that 68% of women used contraception consistently. Women who used contraception consistently accounted for only 5% of the 3.4 million pregnancies that happened that year. So women who are not using contraception or are using it inconsistently account for 95% of unintended pregnancies. And I think this can be kind of like oh, well, duh, Kyl, that's obvious. But I think that it's really telling when you can see it in these pie charts. When people have access to a range of contraceptive method options and they're not facing economic barriers or or geographic barriers or biased provider barriers, they are able to get the methods that they want, and their likelihood of experiencing an unintended pregnancy is dramatically reduced. There are numerous health and social and economic implications associated with unintended pregnancy and birth, but here I'm just going to highlight 6. So unintended pregnancy is associated with delayed prenatal care. Maybe people don't realize they're pregnant, they weren't trying to get pregnant, they have barriers to getting into care. If they don't have any health insurance and they have to self-pay, it can be very difficult for them to even initiate prenatal care. Unintended pregnancies are associated with preterm and low weight births. For a lot of the same reasons why people are experiencing unintended pregnancy and being delayed into prenatal care. Women who have unintended births are more likely to experience postpartum depression and anxiety than women with intended births. So we also need to be making sure that we're seeing this kind of as a holistic issue and making sure that we are screening new moms about pregnancy intention, right? And being able to talk to them about the realities of maybe they were or weren't planning for that. A major reason many women don't want to become pregnant is because they haven't finished high school or college, or they have career goals that they want to achieve before starting or growing a family. We know that 66% of women who have children after they have enrolled in college don't finish. And so we really want to be making sure that if people are able to have the ability to delay their pregnancies if that's what they want to be able to achieve their educational and economic goals. Unintended pregnancies can also lead to relationship tension and dissatisfaction or disillusion. And while we aim to focus on individuals and couples and families, and they are our primary focus at helping them achieve their reproductive goals is what we want, we do also need to acknowledge that unintended births are very costly to publicly funded systems. 1 in 3 Medicaid-funded births was unintended, and they're associated with poor birth outcomes and potential NICU stays. And by no means do we want to be putting price tags on these things, but I think it's important we need to talk about it. There are policymakers and providers and patient advocates who are committed to reducing the rate of unintended pregnancy in Utah and the U.S., and it is a local and national public health goal. Helping people decide if and when they get pregnant is the right thing to do. So as a healthcare provider or a community health worker, assessing a patient's pregnancy intentions and attitudes should be incorporated into every visit. And it's simple to do, especially because if somebody's experiencing a pregnancy or a birth, it can have lifelong ramifications. And so incorporating that into our preventative care makes a lot of sense. So asking a client, regardless of gender, asking men, women, asking them if they want to have a child or if having more children, or if they want to have more children, it can just at least start the conversation. And asking a client how you can support them in achieving their family planning goals can help them have healthier pregnancies, because you could help do some preconception counseling with them, tell them about prenatal pills and maybe some healthy behaviors that they could be doing to improve their pregnancy and birth outcomes. Or maybe people will say, you know, I don't want to get pregnant, and you can start to have a conversation with them about contraception. Patients want providers to bring this up. I think a lot of providers will think that their patients will bring it up if it's something that they're interested in, but time and time again, we are hearing from patients that they want providers to broach the subject. So Patty Kaysen is going to be the speaker next week, and she's going to be talking about patient-centered counseling, and she's incredible. And I think that what she's going to talk about will really help you employ some new skills into your practice. But I just wanted to touch briefly on it because there is a critical importance of providers broaching the subject with their patients in a non-judgmental way that supports each patient's unique desires. Something that we want to make sure, you know, every provider is aware of is that you aren't a barrier to somebody's contraceptive care. So many Utahns are facing geographic and economic barriers. They live in communities that don't have any health centers, and they might have to drive hours for an appointment. They might live in a community that has a health center, but the providers aren't trained or aren't comfortable or confident or have different reasons or excuses for not providing the comprehensive range of methods, including IUDs and implants. People may not feel comfortable seeking contraceptive care in rural areas or small towns where they might feel judged. And so there's some social and geographic and economic barriers, and we just want to make sure that providers are one of them. So we have over 150,000 Utahns who are in need of publicly funded contraceptive care and are falling in what's called the contraceptive coverage gap. They don't qualify for Medicaid, they can't afford private health insurance, they don't work for a company that offers health insurance, they might work for a company that offers health insurance but doesn't cover contraception. Maybe they can't afford to pay out of pocket for the device that they want, which could be up to $1,000. So these people in our community are the most at risk of unintended pregnancy, and you really have to come up with some creative solutions to help them. We want to ensure that you wonderful providers are practicing at the top of your license and that you see the value in being a contraceptive expert and being able to provide any contraceptive method that your patients want, which is why you are all the first to know and be invited to the Family Planning Elevated Contraceptive Education and Training Conference. It's going to be on Friday, January 18th. It's a full-day conference. It's going to be at the University of Utah Guest House. The conference is going to be able to provide you with hands-on IUD training and implant training and all other contraceptive methods. And if you're already comfortable with providing these methods, you'll be able to participate in a Train the Trainer program and become a valuable champion for training other providers in your community. So the conference has something for every member of your health center staff. From medical assistants, we'd be teaching them how to do contraceptive counseling and to set up the instrument trays for LARC insertions and removals, for billers so that they're making sure that they're capitalizing and it's making sure that this is working for the business model of the health center, and receptionists so that they understand how long one of these appointments takes so that they understand that with scheduling. The registration fee is $25, and scholarships and travel and accommodation grants are going to be available. But please just save the date, and we're going to have more details available for you even before this REPP series ends in 5 weeks. I'm going to hold on the questions because we have some more speakers today, but what you can do is in the sidebar there's a chat, and so you can type any questions you want there about what I've talked about, and we can address them at the end. We'll have about 15 to 20 minutes for a Q&A, but also this is my contact information, kyl.myers@hsc.utah.edu. If you have any questions about anything, it is my job to help make sure that you are able to provide the best care you can to your patients in Utah. So I will end there, and we'll get it queued up for Liz and Katie.